Good evening, everyone. Thank you for joining us again tonight for a COVID recovery update from the Hunter New England and Central Coast Primary Health Network and our partners at the Hunter New England and Central Coast local health districts. And tonight we're joined by a special guest tonight who I'll introduce shortly. Tonight our focus is on residential aged care or care of older people. But as always, we'll begin by acknowledging that today, wherever we are across this region, we're meeting on Aboriginal land, and we'll acknowledge elders past and present and thank them for their ongoing stewardship of this place. We should also acknowledge the particular challenges that this particular pandemic is providing for them. Also, while I'm here, I'd really like to recognise the work that everybody out there is doing in primary care, in residential aged care, in trying to keep our communities safe. And people are working so very hard, and it's just wonderful to be able to give you an update tonight and hopefully some of the information that you're really seeking. So tonight, as always, we're joined by a panel of experts who are ready and waiting to answer your questions. So for those of you who are new to the webinar setting, you can log on to Slido. The information is in the invitation. The hashtag for tonight is PHN10, I believe. PHN10, everyone's nodding. And we already have some questions, and we're looking forward to hearing some more from you so that we can make the best use of the time. Tonight we'll have some short presentations and updates from our experts, and then we will facilitate a discussion. So we really do need your questions. If there are questions that are already there that you're particularly interested in, just like them, and that will bump them up the list, and we'll make sure that those are the questions that we address. So I'll introduce the panel, who are some on screen, some not, because we're in various places tonight. So tonight we'll be joined by Dr. Tony Merritt from the Public Health Unit at Hunter New England Local Health District, Dr. Carolyn Hullig who's the Medical Director of Emergency Medicine. Carolyn is from the Belmont ED. How are Carolyn? Dr. John Ferguson, who's an infectious diseases physician from Hunter New England Local Health District. Hayley Ryan, who's here with us in the building tonight. Hayley's the Practice Excellent Lead and Clinical Nurse Consultant for Wound Management at New South Wales and ACT Uniting. So thanks, Hayley. And also online, we'll have Mel Pickering, who's the Acting Director of Nursing for Community Chronic and Complex Care from the Central Coast Local Health District, who'll be able to help answer questions specifically related to the Central Coast. So without further ado, I will throw to Tony. I was just seeing if I had to open Tony's presentation. So throw to Dr. Tony Merritt from the Public Health Unit. Thank you, Tony.
Thank you very much, and great to be with everybody again. So we're connecting remotely. I'm watching myself slightly out of sync, and I believe Todd and colleagues are going to control the presentation from there. So let's launch into that. I sent this across late morning, and I promised that, goodness me, my laptop wants to restart. I promised that it would be out of date by the time we got here, and it certainly is. There's all sorts of things happening at the moment. Have we got that presentation to start? Fantastic. So I'll keep this really brief. Really focus on the questions. So next slide is this one you've seen many times, gives us that hint of the international scene. We hear this every night: over 11 million cases, over 500,000 deaths, and just horrifying level of intensity in South America there, obviously Brazil, but also other South American countries running rampant in North America. Still plenty of activity in Europe and India, and things changing here. So next slide, please. And so we're moving on to Australia's epicurve, and we've seen that first one for ages, and this tail that we're, well, that's no longer a tail, but increasing activity that we're in the middle of now is increasingly concerning. So just a couple of slides to unpack this a little bit more. Clearly lots of activity in Victoria as we speak. So next slide. And a real concern, of course, that we're working into, let's call it a second peak or a second wave. In any case, something analogous to the experience in the past. We've all seen this when there was that brief lull between waves back in 1919. These are deaths due to pandemic influenza, when restrictions were relaxed and things came back with a vengeance over winter. Next slide. So just a little bit more detail. The epi across the country is dramatically different at the moment. We know there are many states and territories with essentially no community transmission, and it's been very quiet in New South Wales. I think if you'd asked us 3 months ago whether we thought we could get to this point, we would have been sounding extremely optimistic. But if you look at New South Wales data, modest numbers, and the vast bulk are international. So the dark, so New South Wales on the bottom, that's counts of new cases by day. The dark blue, overseas acquired. And I think in the last 7-day period, 51 new cases in New South Wales and 50 arrived internationally. And that's overwhelmingly the story, and why keeping our border controls continues to be just a critical part of our protections against COVID. The story in Victoria clearly dramatically different. So different colours there. The light blue, so firstly, dramatically increased numbers. The scale there, if we added today's, I think it's up closer to 200, would be dramatically different. So things look to be well on the rise still in Victoria. Lots under investigation, of course, recently, but lots of local transmission, still a smattering of international arrivals. So dramatically different picture. And that's exercising our Victorian colleagues, but lots of us in New South Wales as well. Next slide. And so locally, for your interest, we have some staff deployed in Victoria. We've surged our operations staff again, so we're interviewing Victorian cases and contacts. It's a very collegiate approach right across New South Wales, helping colleagues. But there's activity locally here, and this, if you just retain one message from this little epi update locally, it's that COVID is certainly with us again. Look, we've had a long period with very few cases. I had to manually add that dot. This is last night's case. So there's a person who didn't acquire their infection locally, but we've now got a substantial group of close contacts, some of whom I feel very confident will become cases. They're in quarantine here in Newcastle, and we had an infectious traveller from Melbourne last week who was in the greater Newcastle Hunter New England region. So we've had potential for local transmission that's really significant in the last week, and it remains just absolutely critical that we are vigilant for people who might have mild symptoms. The circle around that case there, it's again another example of someone who fit person, no background health issues, just a slightly sore throat and runny nose. So the sort of thing that we would not pay attention to normally, and it's just going to be so significant for all those people now entering 2 weeks of quarantine. So we're really back in the thick of things. Next slide, please. So really important for everyone to be vigilant in terms of testing. But, with all of this epi, clearly people who have come from some parts of Victoria should trigger great interest and change the threshold for our willingness to test. This is very much a moving feast. You probably heard on the news that large parts of Melbourne, a much larger part of Melbourne, back into proper lockdown. The border closes tonight at midnight, and essentially all of Victoria will be treated as a hotspot. So people who've been in Victoria in the last 14 days need, if they're still in New South Wales, need to self-isolate. And it's isolated in exactly the same way we would have isolated someone in the past who was a close contact of COVID. So proper isolation with very few reasons to be out and about. And those people simply, we'll go on to the next slide. There's definitely an increased risk of having COVID and transmitting, particularly into high-risk settings. So when I wrote this slide this morning, it was accurate then. People from Greater Melbourne should not be either working in or visiting aged care. They certainly shouldn't be visiting any of our healthcare facilities. And from midnight to night, you can substitute anywhere in Victoria for Greater Melbourne as the situation continues to evolve. And we may well come back to that again later. Next slide, please. Testing, just a brief plug. You've heard this before, but really low threshold to testing people with symptoms. We're not keen to test asymptomatic people, except in particular public health triggered circumstances, but anybody with even very mild respiratory symptoms or fever, or just isolated loss of smell or taste. So any of those on their own ought to be a trigger for testing, and everyone who is tested ought to isolate and remain isolated until that result comes back. Thank you. Next slide. And a reminder that there was that really substantial change in the criteria for release from isolation a couple of weeks ago now. So it's for the vast majority of people, it's a time-based, so 10 days from onset of symptoms or 10 days from release from hospital, whichever is the later, with swabs only required for that relatively small group who have really substantial immunocompromise. And we're using the criteria that are there in the immunisation handbook for the live zoster vaccine contraindications. And the next slide. And just one on, clearly we've had some really troubling circumstances with outbreaks of COVID in aged care in New South Wales, and Newmarch and Dorothy, Henderson. The story internationally continues to be just profoundly disastrous. This is a busy slide out of the European CDC, and lots of data there. But if you look at that column I've highlighted, percentage of all COVID-19 deaths in the country attributed to people in long-term care facilities, and you'll see between sort of 25 and 80% of deaths occurring in aged care facilities, and just pick one there, Spain. So 20,000 people dying in aged care related outbreaks are just absolutely catastrophic, exactly as we know this virus can be. I think that might be the end, or just next slide. Great, so I'll leave it there. Designed to be brief. No, we won't go into that yet unless there are questions. And yeah, back to you. Thank you. I look forward to your questions.
This up to date when it's such a moving feast, as you say, so we very much appreciate that. I will, I'm just opening Carolyn's slides now, and I will introduce Dr. Carolyn Harlick, who's going to talk to us about advanced care planning. Over to you, Carolyn. Thanks.
Thanks, Catherine. Hi, everyone. I've spoken about this a few weeks ago, and there was just a few more questions and some questions that came up through Slido. So I thought that we would... I thought we'd go through it in a little bit more detail. I do not consider myself to be an advanced care planning expert, but I'm happy to talk about it and answer questions. So I think the most important thing is there's some confusion around the nomenclature, and for me, I think it's important to know that advanced care planning is a process rather than a thing. And it's really a conversation that's ongoing and needs to look at basically what does that person want, or what do you want into the future when you're maybe not able to speak for yourselves. And it's not just about do you want to be intubated, do you want to be in ICU, but it's around your values, your belief, your wishes, that if you're in the circumstance where you can't actually speak for yourself, that you would actually get the medical care that you wanted. And I think the other important part about that is that it also is being communicated both to the family and the people that you want to know, but also the general practitioners involved. Sometimes GPs are involved with writing plans, sometimes they're not. But it's really important that all the doctors and nurses and health professionals that are involved with your care actually know that you're having conversations around advanced care planning. So an advanced care directive is a different thing. So an advanced care directive is a thing, and it can be part of the process. And I suppose in the emergency department, it always comes up, is this a directive, is this a plan, what is, do we have to follow it, do we not have to follow it? So there's a few things that need to happen in order for it to be called a directive. So the first thing is that a person can only have an advanced care directive if they wrote the plan themselves, they wrote it voluntarily, and also that they actually have capacity in order to understand that advanced care directive. And I think that's probably the most important thing. So for a lot of our residents in aged care facilities with high levels of cognitive impairment, some of those residents may have had capacity to write a directive, but many of them won't. So that's probably one of the most important things. Some of them can be very specific and detailed about treatment that they would or wouldn't want, and sometimes it's not. But the other important part about it is it needs to have written for a person, free will, and also that when you're interpreting it again as a doctor, that it is actually current and is related to the circumstances that you have at hand. So capacity, I find capacity an extremely complicated issue. And capacity is something that is specific to the decision that person is making. So a person might have capacity to decide what they want to have for lunch, or whether they want to go on a bus trip or not, but they may not have capacity to change their will or sell their house. So it kind of depends on where the person is up to in terms of the course of their cognitive impairment. So as I said, just because someone has dementia doesn't actually mean that they don't have capacity. So the legal test, and this is a legal concept, is that the person understands, in order for a person to have capacity to make a decision, they have to understand the decision that they're making. They have to be able to retain the information that they're referring to, and they need to understand the consequences of their decision. And then they need to be able to use that information and interpret that information in order to make a decision, and then they need to explain the decision and communicate it back to you as the clinician. So I suppose a good example for me is in the emergency department. Earlier in the week there was a 79-year-old woman who is a pretty heavy drinker, who had been laying on the floor all night and hadn't been able to get up. She was incontinent of urine and faeces because she couldn't move. She had a vital call at home that she didn't use, and she said she was going home. So she said she wasn't staying in hospital. So I suppose she needs to be able to say, well, so we talked about, so if you're going to go home, how are you going to get home? How are you going to get there? Who's going to look after you? And ultimately, we kept her in hospital. But yeah, it can be very tricky, I think. And again, I'm happy to talk about that a bit more if people have some questions related to that. So we did an advanced care planning audit at Belmont Hospital, and we looked at 2 months, I think, worth of patients from aged care facilities, and we came up with 92 patients. And I suppose the first thing is to say about half of them had advanced care planning documentation, but 69% of them had cognitive impairment. And of the patients who had advanced care planning documentation, we only knew who the person responsible was in 92% of the cases. And the documentation that came, their medical treatment and their end-of-life wishes were, less often documented, and their values were really rarely documented. So for me as an emergency physician, seeing a really confused and distressed patient in the ED who's come late at night, who has no family with them and no family available when you try to talk to them on the phone, it can be really difficult to interpret the advanced care planning documentation that we receive in order to be able to do the best thing for what that patient would actually want. And yeah, it can be, some of the patients, the documentation says that they don't want to be transferred to hospital. So for me, that's actually really tricky, because you think, well, now what am I going to do? They're in the emergency department, we've called an ambulance, we can't talk to their family. They say they don't want any treatment, what should I do next? So yeah, challenging. Why should people have an advanced care directive? So there's actually been a randomised controlled trial from Melbourne, and I can't remember how many people enrolled in the trial, but it was a few hundred people. And basically they did an audit after the person had died, which is kind of interesting. And basically they were much more likely to receive the care that they wanted. The families were much happier that the patients had actually received the care that they also wanted, but also that they were happy with the quality of the patient's death, and they were satisfied themselves with the quality of the patient's death. So kind of interesting that the perception around that the person got what they wanted versus what the family got what they wanted was slightly different, but important, because the families are living on, but our patient in front of us is the person who's dying. So again, pretty strong evidence that advanced care directives, when you can actually write them, really help. So what do we need to know as clinicians? I suppose it's important to know that an advanced care directive is a legal document, and that we as clinicians can't actually override a legally written advanced care directive, not even the enduring guardian. And they, as I said, they need to be written by an over 18-year-old. And anything else that's a documentation where even the person signed it is an advanced care plan, not an advanced care directive. And I think that as clinicians, we can be pretty comfortable that an advanced care plan and an advanced care directive will actually help us with our decision making, but also we can be comfortable that at least the families probably had previous conversations regarding the person that's in front of us, and that we can talk with the family about what the person would want in these circumstances. And I think the most important thing about advanced care planning is that it is as I said, an ongoing journey really, and that things change over time. And that really, for me, the documentation, the most important part of it is we actually know who the person responsible is, so that we can talk to the right family member, because as you all know, there can sometimes be conflict in family around decision making, and that we can continue with this conversation around what the person would want in these circumstances. And I think the other thing is, in the emergency department, sometimes, as I said earlier, the advanced care directive needs to be current, and we see patients where the advanced care plan hasn't been renewed for a few years. So again, all these different things I think can be triggers for aged care facilities to think about renewing and updating and just confirming that the advanced care plans actually reflects what the person would want. I've written down there, person responsible, enduring guardian. So there's a legal hierarchy around who the person responsible is, but I think the highest one is the enduring guardian. And I think, again, it can be really tricky in the ED, but again, I'm sure tricky in aged care facilities as well, knowing that you're actually talking to the right person. And I also wonder if some of the media that came out of the outbreaks for COVID in Sydney, with families who are unhappy, whether some of that was actually related to the fact that the person responsible wasn't necessarily telling everyone else in the family what was going on. I think the other things to think about is that as a doctor or a clinician, we really can't be forced into delivering futile treatment, and we're not required to ever deliver futile treatment, even if an advanced care plan or directive suggests otherwise. And that, really symptom management comfort measures is really the things that we do really well, and that's not withdrawing treatment, it's actually delivering treatment. And to deliver good end-of-life care symptom management comfort measure is actually a pretty intensive thing to do. Antibiotics are a controversial part of end-of-life care. Some people say that it doesn't necessarily improve symptoms, but some say, depending on the infection, antibiotics may help to relieve symptoms at the end of life. And I think the other thing is what I'm going to touch on is goals of care. So in the hospital, we fill out this form on the right-hand side. It's called an adult resuscitation plan. And I suppose we use the advanced care planning documentation that we receive in order to document what that person would want if they no longer had capacity to speak for themselves. And they're the hospital triggers around when we should do an adult resuscitation plan. But more than 2 admissions, metastatic disease, frailty, including cognitive impairment. Would I be surprised if the patient dies in the next 6 to 12 months? As I said, the person already has an advanced care plan or directive. And for us, a lot of the patients where you're not really certain that they're going to recover, and I always say to the patients, look, you know, if it's 2 o'clock in the morning and something's happened, what do you want us to actually do for you? And most people, I find, in the ED are very happy to talk about their adult resuscitation plan. Hospital is risky. I've shown you this slide before, but people from aged care facilities, 38% of them in the studies will get delirium in hospital. Much higher rates of pressure injuries, much higher rates of falls, much higher rates of dying in hospital. So hospitalisation isn't necessarily a safer thing to do for someone particularly who's frail and complex from an aged care facility. I'm not going to go through all this slide, but we have a new ACE manual that hopefully most of you have received, and if you haven't, I'm sure if you talk to the Primary Health Network and Catherine and her team, and Ros Barker, who's our aged care emergency CNC, we can send out new copies of it. But there's lots of flowcharts that we've updated in relation to mostly symptom management. But this is actually a really important one, I think, around goals of care. And I think particularly for hospital doctors, I think many of us are trained and think in a curative mindset, which is the box on the left-hand side. And actually many of our patients are actually more in the palliative stage of their life. And if you remember, the average length of stay of people in aged care facilities in Australia is around 18 months. So really the surprise question is almost answered just by the fact you're frail enough and complex enough to be admitted to an aged care facility. So I think, and from an ED perspective, what we really want to know from the aged care facilities is what do you want us to do when this person gets to hospital? Do you want us to find out has the person got a fractured wrist, or do you want us to fix their atrial fibrillation, their heart failure, their COPD, their diabetes? So I think we actually really need to know what's the purpose of the transfer to the emergency department. And then I think we're much more likely to deliver the care that the patients want. In the ED, we've been using the clinical frailty scale. And there's an app available. If you just Google clinical frailty scale, it's a really good app and it goes through all these questions. But if you look at it, most people who live in aged care facilities have already scored a score of 6 before they've even got to the emergency department. And the scale is based on their best, on how they are like 2 weeks before. It's not related to how they are in the ED today. And this is some outcomes related to the clinical frailty scale. So as you can see, someone with a score of 6, the inpatient mortality is 6%. So this is not related to COVID, this is just from being transferred to hospital. So the frailer you are, the more likely you are to die in hospital. And I suppose, again, thinking back to that goals of care spectrum, you're much more in the palliative end of life spectrum around what we can do to maximise your quality of life than we are around cure. Last 2 things are the health pathways. So we've put a lot of work into the health pathways. The first one is just the one that we've talked about before, which is assessment and management of patients with COVID in aged care facilities, and there's a huge amount of resources in there. We've really not written anything that's new, but we're just trying to put all the different resources across many different government organisations together into one document so that there's one place to go to. And then the second one, which is relatively new, is the outbreak preparation and response. And again, we've talked to a lot of you in our weekly and fortnightly aged care emergency webinars, which are going really well. But again, there's lots of resources in there for you. And then here's some of the websites of documents that I've talked about. So the CFS Clinical Frailty Scale website, there's a really big website there, including the app from the NHS. There's a really good online training program called End of Life Directions for Aged Care. There's another one called End of Life Law for law as well. And both of them have got modules that you can do to improve knowledge on end of life. Capacity Australia has a fabulous website on what is capacity, and the ACE manual we just talked about, and then health pathways, again, that you will know about. So thank you, everybody.
Thanks, Carolyn. Thanks very much, Carolyn. And Carolyn will be keen to answer questions as well. So I'm just going to open the next presentation and introduce Dr. John Ferguson, who I think is this one over here. Is that you? There you go. Who's going to talk to us about some infection control measures. There it is. Over to you, John. Thanks.
Thanks, Catherine. So we're going to revisit some topics that we've done before, but I guess the central issue in aged care is it's not really a healthcare environment, it's more like a home environment. And there are all sorts of challenges around infection control management in such environments, including cooperation of residents who may have intellectual impairment, the frequent contact that residents have with each other, and shared surfaces, the sort of furnishings that make it very difficult to clean and decontaminate areas. And so all of those things add to the challenge, and part of the new normal, I think, in aged care needs to be lateral thinking around physical distancing, around cohorting different groups from different wings with different groups of staff, and avoiding crossover in those groups so that you minimise the capacity for spread of viruses like COVID through a facility. And I'm sure Carolyn's been much endeavoured in thinking this through in the outbreak response, but preparation is all. Now, there are several salutary tales. This is a picture of Newmarch House. We're really awaiting a proper objective review of what went on there, and that is taking place at the moment. So I'm not going to talk about Newmarch House. Suffice to say that they were probably fairly slow off the mark in taking action. A much better story comes out of the Dorothy Henderson Lodge in New South Wales. This was an 80-bed facility that diagnosed a case in an AIN at the beginning of March, and soon after 4 residents, 2 more staff were diagnosed, and then a brace of other cases as they went on. But they had very early intervention with infection control expertise and additional expertise coming on board. They implemented effective measures, and they had a good story really, because they contained this outbreak as rapidly as they could. We always understand that even a solitary case within aged care usually means that there's been transmission already, and this indeed was the case here. And it took them, they probably had a second brace of cases, 8 to 16th of March, 4 more residents. They then screened everyone on the 20th of March and picked up 6 further positives, and so on. So 17 residents and all 5 staff. So this is a relatively small cohort out of an 80-bed facility with many staff. And I think the bottom line was that this was as well managed as it could have been, and the mortality was significant at 6 individuals, 6 residents dying, and almost half the cases already infected before containment measures were fully implemented, and another wave of exposures after 1 to 2 weeks. So this is, and the management of outbreaks in these facilities, I'm sure you're aware, is countered by all the adverse effects of confinement of the residents, and that's been very tricky to manage in places like Newmarch House. But I think the early intervention of specialist advice, the daily attendance by a doctor who had continuity of care over those residents really played a big role. Now contrast this quickly to the Washington case study that is famous from the New England Journal. Here we had a 73-year-old being admitted to hospital, several almost a week into her illness. A physician at that hospital eventually tested her on the next slide, but she was already in hypoxic respiratory failure and had required oxygen for 5 days prior to hospitalisation from the aged care facility. So you can well imagine what had already taken place in terms of transmission. So 4 days after admission, the clinician concerned, and this was fairly early days, had the presence of mind to test for COVID and got a positive result a day later. And eventually 167 cases were linked to the facility, 101 residents, 50 staff, 16 visitors, with a very significant mortality. Now, if you look at the epi curve, it's quite interesting because the index case on February 27 is soon after followed by a whole spate of detections indicating that the spread of those to those individuals occurred probably 5 to 7 days prior to March 1st. And so this was alive and well there for some time before it was recognised in a secondary way from the hospital visit. And then there's this secondary peak, March 9th, which indicates a second wave of infections, transmissions from those initial, that initial peak. So continuing transmission within the facility, across to other parts of the facility, and it was a real nightmare. And they found a range of issues. Staff had been working while symptomatic, staff that moved between the different parts of this aged care facility, inadequate familiarity with standard infection control precautions, and PPE shortages, and the lack of recognition of cases, so they really didn't have the surveillance in place at that time. So Carolyn and Tony have fixed that up for us big time, so we don't need to worry about that, but we do need to worry because it's reading these sort of case studies really makes you question, doesn't it, whether you are truly prepared or not. So there are some good national resources. There's the infection control expert group that advises the Chief Medical Officer, has those documents. I'll just pick the eyes out of one of them. And of course CDNA has the central guideline on outbreaks that I'm sure the local guidelines are keyed into. I would say the New Zealand government also has some excellent resources, particularly around preparation of aged care facilities and the sort of practical physical distancing measures and cohorting measures that can be put in place. WHO is also a useful resource, notwithstanding the experts in inverted commas who are taking pot shots at WHO around aerosol transmission. But I think WHO remains mainstream in its advice. They've just updated their overall infection control advice at the end of June, and they still take this hierarchical approach to infection control. And you'll see here that transmission-based precautions and PPE are the lowest rung of risk mitigation. We have to manage things in other ways first. They're the most effective measures, the administrative measures, the standard precautions, the environmental and engineering controls. So the ICEG document really goes through a very similar range of measures to that of the inpatient document, and I'm not going to go through those in detail. Excuse me. That's not a proper cough. And so there are administrative measures, and I think the bottom line here in infection control is always the training of staff. There is the staff provision in the first place, and then the training of those staff so that they really know how to walk the talk infection control wise. So the professional development of the staff, the ongoing professional development of those staff, unless you've got keyed in staff on deck, you can't get anywhere with any of the other measures. So, and those staff need to comply with influenza immunisation, standard precautions, of course, as the mainstay. And then we have to have effective measures for case detection and contact evaluation, and then transmission-based precautions further down the road. The CDNA document has several useful flowcharts. This is the appendix on COVID management, starting with the preparatory tasks. I'm not going to go through that, but that's the Appendix 1. Appendix 2 is a very useful outbreak preparedness checklist that I'm sure Carolyn has referred to, which steps through planning actions, the sort of education that staff, resident and families need, the staffing actions, staff contingency plans if staff fall ill, what plans there are for cohorting staff in the event of an outbreak, PPE stock levels. The second part of the checklist goes around outbreak recognition actions. This is monitoring all the residents, as Carolyn has mentioned. Does your RCF support and encourage staff to report COVID-19 symptoms during the pandemic? Is there a process to notify the facility manager, etc., when a COVID case is suspected? Communication actions, as shown there. So these are all very useful things to go through. They sound like motherhood statements, which are very important, of course. Probably not the right term to use these days. But being systematic about preparation is all in terms of infection control and aged care. We've got a far better chance of preventing problem in the first place. What I mean is prevention is the primary thing, the primary goal of infection control in these environments. Once we have an outbreak situation, we are struggling to catch up because of the sort of environment, all the issues that I've raised before. And so we want to avoid, if at all possible, getting backed into that situation. Now, Hunter New England, Central Coast are periodically having respiratory infection outbreaks, so the Public Health Brigade are well practiced in going into aged care and diagnosing and managing those respiratory infection outbreaks, and we test for COVID, of course. So this is a wonderful way in which outbreak preparedness is maintained in Hunter New England, and Tony Merritt would like to comment on that, I'm sure, but we'll allow him to do so in due course. Thanks very much.
Thanks very much, John. Thanks very much. And while I'm preparing Hayley's slide, and she's coming to join me, just note there are some questions that have been asked on Slido. So if you're interested in, if you would like to make sure that we get to that question, then please, I guess, like it and bump it up. Some of the links, before I'm still got the microphone, some of the documents that John referred to, there are links on health pathways, on the ACE guidelines, and also on the capacity tracker, which we've been talking to the facilities and the general practices about. So there's lots of information on the resource centre there. So there's plenty of places to get good advice on which to base your policies and practice. But Hayley is going to talk to us about some real life experience that they're having. So we really appreciate your time. And there you go. Thanks very much.
Thank you, and thank you for the invitation to come and have a talk to you all today. And in particular, I just want to take a moment to thank all the clinicians working on the front line. Wishes really to all the patients and their loved ones who are affected by this virus. So my talk today, I've themed it looking to the future as COVID-19 requirements really become the new norm. This is our way of living now. So I've got nothing to declare, no conflicts of interest, and I wanted to take you through a journey of the past, the present and the future with Uniting and what we've done to manage this. So today I'm going to actually speak to you about the impact of the COVID-19 that it's had on the healthcare system within Uniting from a leadership perspective. We are certainly well aware of the losses, the challenges and the tragedies that have been associated with this disease, but I'd like to also talk about the opportunities that this has created, and as leaders how we can help our organisations and others to become really more resilient and lead a path to hopefully a brighter future. So let's get into it. This is the past and the present. What we've done at Uniting, it's really been focused on risk management. And everything that the speakers prior to me spoke about, we have actually focused in that area. We've developed policies and procedures. We've updated them. We've screened systems. We've put things in place to make sure that those entering our homes are checked. We've looked at education. We've looked at the best guidance available and posters and toolbox talks. Operationally, we created service level pandemic plans and made sure our teams were aware. Simple things like how to don and doff PPE, how to fit check, all those important requirements. Early identification and isolation of symptomatic people, how do we manage that? And exactly what the doctor spoke about earlier, cohorting to those wings was really important. Working with peak bodies to advocate for transfer to hospital. Review of staffing levels, PPE stock and emergency kits, an increase in infection control measures, including extra cleaning. We looked at transparent communication to consumers, to families, to ambulance services, to even the lab testing services. How do we keep that communication and lines open? We looked at New South Wales and ACT Health for information, and we added all of this onto a frequently asked question website that all staff could look into. And we set up a COVID-19 task force team, and we meet every couple of days. It's quite a large team, but we look at the best known practice that's out there and we implement that into the service. And we put together a flying squad team, and this is something we're very proud of. We actually asked for volunteers within Uniting, so frontline staff who would be willing to put up their hand in the event of an outbreak and come to that service, whether they fly or drive, and be there to be that first responder. And we've received quite a number of applications to do that. And of course, we looked at employee wellbeing programs. I guess one of the things that has really stood out to me during this pandemic is the courage and compassion that I have seen amongst my colleagues. But this time has also exposed some vulnerabilities into the healthcare systems, and something we need to think about. So the biggest question we get, when will we return to normal? Or is the real question, will we? This is really a once-in-a-100-year opportunity to believe in change and drive it. So we have an opportunity here to learn from things that we weren't prepared for and make a real difference. So what I would suggest is forget about talking about the future, because the future is really now. So let's have a look at the opportunities and some things that we did within Uniting. Firstly, it allowed us to accelerate timelines on existing initiatives. We actually pushed forward online home care. We pushed our services with telehealth services. We looked at new protocols. Our seniors gyms, we took them online, and yes, our gyms are starting to open up now, but we had to really spend a lot of time online. We expanded and evolved our service delivery by digital home care and wellbeing focus for our staff and our residents. And we looked at innovations, so internal social media sites. We actually spent a lot of time doing this. We had online platforms for our business to stay connected, so we used the Teams platform. We looked at virtual learnings, augmented reality, and we also are starting to look now at artificial intelligence. But these are some of the opportunities that we can actually learn from this pandemic. So what are the next steps for Uniting's future? Well, it's about ongoing health regulation monitoring. We need to stay current. Our wonderful directors have worked so hard and tirelessly throughout this whole process, and one in particular, Saviour Bahaja, who is our Director for Ageing, he has made sure that we've stayed connected with the people we serve, so our residents and our clients. He made sure that every fortnight they get communications and updates of the latest information. We are starting to build a climate for change. And if I think about a climate for change, the first thing that comes to me is Martin Luther King and his talk on I Have a Dream. And people really bought into that process because there was a vision there. And that's what we now need to do. How do we have a vision for the future? Well, that starts with motivation. So how do we get motivation into our teams, and how do we avoid complacency? And the reason I'm bringing up complacency tonight is because we're starting to see that. We're starting to see restrictions are starting to decrease. People are returning back into the office and not working from home, and we're starting to see people not so much respecting the social distance and all those other bits and pieces that we need to be mindful of. So to overcome some of these things, we started putting little pods of cleaning products around that people could be self-accountable for and clean their own desk. So those little things that just put in the forefront of the person's mind to focus on what's required. And the other thing that we have focused on very much, besides looking at our Baptist Care and our Noose March and staying in contact with those aged care homes, is reviewing the current research. And I have to say, Dr. Ferguson and I read the same research by the looks of things, so I have the same topic here, so I won't go into that because he's done a wonderful job, but that disparity between how long that took to review was an indication of where we are today. But those things that came out of this study, I have to be proud today and stand here and say that Uniting really focused on these areas. Staff members working with symptoms, we put it out very clearly from the start, if you have the slightest symptom, you do not come to work. That working in more than one facility, you are now required for Uniting to go and speak to your manager and come up with a plan of defence. One of the things that came up in the study, inadequate understanding of required precautions. We focused heavily on our plans and made sure our teams on the front line could actually read them and understand them. Our PPE supply, this is a problem globally. We know this. We know that everyone struggled to get PPE, so we started really early in trying to establish good PPE requirements, and we set up 15 hubs across New South Wales and ACT. And in those hubs, we can actually support a number of days should any of our services go into an outbreak. And delayed recognition of cases. So how do we make sure our staff are aware of what to look for in the symptoms? So that brings me to my next piece of literature that we looked at, which talks about asymptomatic and pre-symptomatic infections in relation to long-term care. What this study actually showed is that 76 out of the 82 residents that were tested, 30% were positive for COVID. But interestingly, 13 were asymptomatic when they were tested. 7 days after testing, 10 became symptomatic. So my point here and what came out of this study is that symptom screening could initially fail to identify infection for the aged person. So they concluded in this study, if you base your screening on symptoms, you could really fail to identify coronavirus infection. So it makes you rethink, is screening with a temperature enough? So it brings me to this study. The coronavirus disease in 2019 in geriatrics in a long-term care facility. Of course, these are all overseas. But what this study found was older adults may be afebrile. They may have more common symptoms like malaise or low-grade fevers. They show signs of tachycardia and hypertension and altered mental state. So the findings overall was any significant change in status should prompt a COVID-19 evaluation. In fact, enhanced daily monitoring of clinical status is required, not just temperatures. So we at Uniting now need to reshape how we've done things, and what do we need to change? Well, we need to re-establish a focus. We need to refocus on our frequently asked questions and talk to our staff about what we can do and what's needed. We need to update our screening tools as things change, and we've already done that to include the Melbourne requirements. We need to stay connected with programs that focus on the consumer, that focus on staff. And I have to stress, business as usual. You know, somebody mentioned earlier about the pressure injuries for admission to hospital. These are the business as usuals that we cannot let go of. And on the screen that you see now, these are some of the things that we have in the front of computers. Every time a staff member opens it, they see a reminder of what they need to do. So when we talk about staying connected, we went down the track of a wonderful program called Move and Groove. This allowed every consumer in our homes to stay connected to the outside world. Yes, it gave you iPads and you were able to connect to your family, but it also gave you church services. It also gave you relaxation. It even gave you exercise programs. It even gave you social discos and things. So all with this app that we were able to establish. But none of this would have happened if we didn't have the wonderful work of the COVID-19 response team. And unfortunately, I don't have all their photos on the screen today, but this was at one of our meetings. And it's been pivotal and a real pleasure to work with this team. And I cannot thank my manager the most, Lana Richards, who agreed to put on our Captain COVID cape and let us all know that our Uniting teams are to the rescue. So in summary of Uniting's initiatives, we did prepare early. We instigated the response. We focused on governance and the workforce and how we restructure that. We focused on the consumer safety and their well-being. We informed and coordinated good communication, and now the focus is that step-down planning. So what I leave you with tonight is that we are in an evolving world. Things have changed for us. So the words that I would like to leave you all with tonight is yesterday is not ours to recover, but tomorrow is ours to win or lose. Thank you so much.
Thanks very much, Hayley. And it is reassuring, and every time we talk with various aged care facilities around the region, we are reassured about how hard you're working and how prepared people are becoming. Before we throw to our panel, I will just introduce Melissa Pickering, who's joining us tonight from somewhere on the beautiful Central Coast, in front of a very grey wall, and just ask Mel for a quick update on services from the Central Coast LHD, and then we're ready for your questions, so please be ready to fire them at us.
Thank you, Catherine. I just wanted to take this opportunity to, I guess, remind those services out there, and also, I guess, to share with those services that don't know about some of the work we've been doing on the Central Coast in relation to the aged care response team and the support that we can provide to the residential aged care facilities on the Central Coast. We do have, as part of our aged care response team, which is the nursing team, we have access to 2 aged care nurse practitioners, as well as the registered nursing staff that do work 7 days a week from 8 a.m. right through till 7:30 p.m. each evening. We also have access to our dementia and behavioural support services on the Central Coast, our palliative aged care service, community allied health, our acute post-acute care service. There's also older persons mental health, the behavioural assessment intervention service, as well as we can access our specialist medical colleagues if required to support the residential aged care facilities. Some of the things that we're able to support in is provision of care, education, and that education can be planned education and also just on the run education, which we found has been quite beneficial for the staff within facilities to be able to provide, I guess, that on-the-spot education that's relevant to the residents that they're caring for at the time, and it allows the opportunity for the staff at the facilities to ask questions that are relevant right then and now. We're also able to follow up with any care or care planning that's taken place, just to ensure that the plans that were developed in consultation with the resident and the facilities, including the GPs, are actually working, and if required, we're able to support the review of those. The other thing that we do is provide some capacity building within the facilities. So if there are any facilities that feel that there are any gaps in educational knowledge or competency that you'd like some support in, please do reach out to us. You can access the aged care response team through our community health access and intake service, which is our referral processing and triaging centre. When you do phone through to that community health access and intake, you'll be put directly through to a nursing, a registered nurse or a clinical nurse specialist who'll be able to assist you with ensuring that we're able to provide a timely response. Just a reminder on that phone number, it's 1300 725 565. But no, thank you, Catherine, for the opportunity to, I guess, just to provide a bit of an update around our aged care response team and the services that we're able to provide on the Central Coast.
Thanks very much, Mel. So we've now got some of our panel here in the hot seats and some of the panel on the screen. So I do have some questions. I will remind you, please go to Slido and ask the hardest questions you can find and take advantage of our experts while they're here. Tony, the first question is for you, and I think you touched on this, but we would just like some confirmation. If a person has been in Victoria in the last 14 days and are now in New South Wales, are they required to self-isolate from now for 14 days?
Well, Catherine, it depends what time it is when you ask the question. So, look, it really is a moving feast. I can say right now, anybody who's been in the Greater Melbourne area is defined as we speak as a hotspot area. And so anybody who has been in the Greater Melbourne area in the last 14 days is required to self-isolate if they have a valid reason to even be in New South Wales. So very many people are excluded from travelling from the hotspot areas. But if you left, say, an eastern suburbs location that wasn't a hotspot at the time a week ago, and you're on holidays in Hunter, New England at the moment, and it's less than 14 days since you left what's now a hotspot, then you're absolutely right. You're required to self-isolate and not go out except for those very constrained number of reasons. My understanding is that from midnight, all of Victoria will be considered a hotspot, so we'll wait to see the exact wording in the public health order that is was being drafted just an hour or two ago. But if I'm right about that, then the answer to that question is from tomorrow, that'll definitely be the case. So somebody from anywhere in Victoria who was there inside the last 14 days will have very limited reasons to validly legally be in New South Wales. And if they're here, for example, a resident, someone who needs to be here for other reasons, then they will need to self-isolate at home. And it's a sort of isolation that we were organising, and all of you were helping to support for people who were contacts of confirmed cases, or in those early days back in March, people who were coming off international exposures and were isolating at home before all the airport quarantine were in place. So it's proper isolation, separated from other people in the house, ideally separate bedroom, separate bathroom, masks on if there needs to be contact in the same space. It's going to be a real challenge. Obviously, lots of people will be caught up with this, given the nature of how quickly this is changing. Do we think that addresses that question?
I think it probably does, but I will just ask a follow-up question in case somebody's thinking about this. So a lot of our audience are from working in residential aged care or general practice. So if they have a staff member who's been to, I'll give you a scenario, went to Melbourne last weekend to visit family and is expected at work tomorrow, we're expecting them not to come to work and to be self-isolated. Is that what you're saying?
Yeah, so what New South Wales Health has publicly published is really clear for aged care, and it's not really clear for general practice. And I guess this was the case often early in the COVID response as well. And so it's been really clear that the hotspots, however defined, dictated for aged care facilities, both in terms of visitors and any staff, whether it was appropriate for them to be at work or not. And so hotspot in the last 14 days meant that it was not appropriate to either visit or be at an aged care facility as a worker. And as hotspots have changed, there is a retrospective element by implication, of course. So at the moment, Greater Melbourne is the hotspot. If you've been in Greater Melbourne in the last 14 days, then the answer is you're absolutely right. Don't visit and don't come to work. It doesn't explicitly set out requirements for general practice. Obviously, New South Wales Government doesn't have jurisdiction in a direct way there. But that would be a very sensible approach to take. If in terms of Hunter, New England health facilities, I guess we have the luxury of being a little bit further away from the border. This is an enormous challenge for people closer to Victoria, but it's a very strict approach being taken in Hunter, New England facilities. I know people were sent home today who were at work doing useful jobs, but as the rules changed, it was identified that in the last 14 days they'd been in hotspot area, and so it's a very low risk approach being taken, and people are being kept out of health facilities. Catherine, does that address that follow-up question?
While I've got you, I'm going to ask you one more follow-up question, and I think I know the answer, but which is possibly not clear yet. So are compassionate exemptions possible for families from Melbourne for residential aged care residents at end of life, acknowledging that at this stage I'm not sure we know how people are going to get back over the border, because I don't know if that part's been clarified. What would your advice be, or John? I'm not sure.
Yeah, so the exemptions, we actually, it's become a really big part of the work that we do. So we've put on an extra person to help manage exemptions, and this is relevant now in lots of contexts. You can imagine there are people coming in from overseas to see loved family members in all sorts of situations where time is so critically of the essence. And so there, we've got a well-established process. This is really a challenging area, and the default position is that people respect the isolation and stay in quarantine or isolation through until the time when they're no longer infectious. And then where it's clear that there really is a risk of a person, for example, passing in the next week or 2 weeks, we will do everything we can to get immediate family members together if that can be done in a safe way that doesn't put other people at risk. And so there's been all sorts of ingenious ways to make that work. So the answer is that is definitely possible, but it's not the default. And so we work to assess the situation. How critical is the timeline? Are we really in a situation where the next couple of days are the key ones to make a meeting work? And then how ingenious can we be for that to be done in a way that's safe? And there are many times when we've just the default is that people complete their isolation and quarantine, and so at times there are some hard decisions to be made as well.
Thanks very much, and appreciate you taking on the hard questions there. I'm going to see, I'm not sure, John, if this is a question for you, so I'll ask you and you can tell me. We believe that someone tested positive recently in New South Wales after 14 days of quarantine and a negative COVID test before they were released. Do you think quarantine should be extended?
I don't think there's any good evidence to show quarantine needs to be extended. We do know that people remain PCR positive for extended periods of time sometimes. Those people are almost always culture negative and not thought to be infectious. And there's been some more detail coming out of international literature on those cases, on people that have recovered, showing that there haven't been any demonstrated second infections in those people, and that those people in recovery phase haven't transmitted infection onto others despite being PCR positive. So I think the measures currently in place of 10 days following illness onset and 3 days, at least 3 days of being well, are quite adequate. The vagary in quarantine is if you're quarantined with a large group and there's contact between the group, you may have transmission at some phase through that 14 days, so that you need to quarantine further length of time. I'm treading into Tony's territory here, but that's certainly the case on cruise ships and in housing communities that can't adequately separate individuals. Tony might like to comment.
Look, I think that it is a fascinating recent case. I guess that the point I'd make is that I don't think 14 days needs to change. That actually has been a formal change in the way the 14 days are counted, and so that is effectively a slightly longer system, back to the way that you and I would count 14 days. But so that has formally changed a week ago. 14 days, I think, is right. I mean, incubation periods, typically the vast majority of people are going to be around that 5 or 6 days, but we know there's a tail, and that there'll be some people who have longer incubation periods right out, and this is the lesson from this recent case, right out to 14 days. And, you know, I think the UK chose a 12-day cutoff, we chose 14, and, you know, 99% of cases at least will have an incubation period that's shorter than that. So it served us really well. I don't think we need to change it. But it is a reminder about why we ask people who we put into quarantine to do that for the whole 14 days, because it is possible for people to become cases right up to the end of that period. And we've imposed that request on literally hundreds and hundreds of people just in Hunter, New England, people who are close contacts. There's a quite a big group right now because of the cases I mentioned earlier who are starting their 14 days in quarantine. It's a huge ask, but it needs to be the whole 14 days because some people will incubate right up and only develop their clinical illness right at the end of that period of time. Thanks.
Thanks, Tony. I might move on to a couple of questions about advanced care planning and directives. Looking at you, Carolyn. There are some questions of one. The first one is, has there been any progress on locating an advanced care directive in the Hunter New England Local Health District records?
It's a good question. I only get asked good questions, don't I? We've got a flag in the system, so CAP, if there's a resuscitation plan written. There are ways of storing documents into CAP, but I don't think there has been a specific way to store advanced care plans, which is what needs to happen. So the plans get stored in our system, but are they accessible to me as a clinician in the ED at 2 o'clock in the morning? Not necessarily, no. But they're in there somewhere.
It sounds like that's a known issue. There's a few requests for that. So.
Yeah, I think so. So I mean, there's been talk about, well, we've got My Health Record, therefore patients people can upload their advanced care plans onto My Health Record, but I just don't. I think it's a bit like advanced care planning in general. Everyone thinks it's everyone else's business. So, should the hospital write the advanced care plan? Should the GP write the plan? Should the nurses in the aged care facility write the plan? And I think storing advanced care plans fits into the same logic. But we do need to fix it, and I will continue to promote that.
Thank you. There's a question about advanced care directives and the challenges of different laws across states. And what would your advice be? And you're nodding there too, Hayley, on what the advice would be for national organisations.
Unfortunately, it's jurisdictional. So even if you're a national organisation, there's different laws in different states. And there is some move to try and bring those all together, but they are different. But that website that I mentioned, End of Life Law, is an online training module and goes through some of those issues. But yeah, again, for people who live in Albury or people who live in Byron Bay, it's a big deal because different advanced care planning laws across New South Wales, Queensland and Victoria.
I was just thinking as you said that, state borders are an issue that we sometimes think are not really necessary, but today they do feel really, really important.
Well, maybe we don't need them, maybe that's the issue. But yeah, no, unfortunately it is a state by state law.
Mm-hmm. Did you have any advice on how you're dealing with that?
I was going to say how we're dealing with it is quite difficult because we have ACT in Uniting and New South Wales and they're under different laws as well. So it makes it very difficult, particularly when you've got people crossing over the border for work as well. So it's very challenging.
Would be the equivalent, wouldn't it?
Yep.
Could I ask a related question? How often should I be updating my advanced care directive?
I think on my slides I talked about some of the triggers. So I think, if you've actually written your own directive, it needs to be current, is one of the requirements for it to be interpreted. And I don't know that in the law it specifically says what current means. But obviously people like in an aged care facility who might have had visits to hospital regularly or conditions are changing rapidly, they're the circumstances certainly when they should be updated.
Or some will do it with the 3rd monthly or 6th monthly case conference. Yeah. One of the challenges, however, is a lot of nurses are faced with family members that just do not want to have that discussion, or the consumer does not want to have that discussion. So it's also guiding those clinicians with how to talk and manage those discussions, which is difficult.
I think so. I think it's interesting, isn't it? Because in the ED I have those conversations every day, but I don't have an ongoing, or some of those patients I have an ongoing relationship with because they're deteriorating and coming back regularly to the ED. If they wave to me from the ambulance bay, I think that's a bad sign. But I think I think most people are actually relieved. There are a few people where I'm actually shocked that they haven't talked about it, but I would suggest that the majority of people have talked about it and are pretty clear around what they want and don't want.
I'd agree with that, but in an aged care environment, I actually find that they don't want to put it on paper. That, oh no, I don't want to make that decision for mum because mum now has dementia. So how do we get over that line? So we actually see a high proportion of that across the aged care industry.
Yeah, so I suppose it goes back to John's point about doing it before you're in an aged care facility.
Exactly.
But I think too that, I mean, I suppose for me, again, as an emergency physician, which is a different perspective, but I think the most important piece of information on the document is who is your person responsible. So if something goes, because again, ED today, a 91-year-old man with 3 different children who don't talk to each other. So, you know, which is fine because that's how families are, but who's the person of those 3 children who's going to actually speak on your behalf?
Or on the flip side, there's 5 people that want to speak on mum or dad's behalf.
Yeah, correct.
And they've all got conflicting requests.
Yeah, that's right. So
I feel for those nurses on the front line.
I think the other thing that I often do too with the families is you're talking about what would the person want. So if your mum could speak to me now, what would she tell us that she would want? Because really what the families want is their mum to be like they were 10 years ago. They don't actually want them to be like they are now. So so I think sometimes if you change the conversation back to the resident or the patient in the hospital, I think that it helps.
Yeah. Yep.
Thank you. There's a kind of follow-up question here, and I think you definitely touched on it in your talk about the frailty tool. I'm wondering, it says, would you recommend using the frailty, it's a hard word, tool in advanced care planning discussions with residents and families? And I'm not sure if anybody has any experience with doing that, but it certainly does look to be a fairly subjective.
So the tool comes from Canada, and Dr. Rockwood, which is kind of interesting, I always want to call him Rookwood, but anyway, he's a geriatrician in Dalhousie in Canada. But they're actually using it in the NHS now a lot in primary care. So again, having a standardised countrywide electronic medical record. They do have triggers in general practice for some of those different tools to be used. There's lots of different frailty tools as in with everything to do with geriatrics. There's too many tools, but the reason why I like the clinical frailty scales is pretty straightforward. You know, there's things like, does the person look after their finance? Can they drive a car? So it's kind of very practical kind of questions that reflects their function and their ability in terms of frailty. So I suspect, again, one of the opportunities out of COVID is in critical care particularly, but I think across the health system, looking at tools that are, what's the right word? Independent of us around, you know, they're a good 90-year-old or they're a good 70-year-old, or like it helps put a specific number and makes us maybe be a bit more scientific, objective. I think that's the word I'm thinking of in our decision making. And again, it's not just because you've got a frailty scale of 7 doesn't mean that you shouldn't be resuscitated, but I just think it helps us in terms of the conversation with the family around this is what it means, this is the kind of outcomes we can expect if you go to ICU and you're intubated and ventilated. It's highly unlikely that you'd come off a ventilator, so I just think it helps to try and put a number against some of those figures around prognosis and outcomes.
Thanks, Carolyn. I do have a question, and then this is the last question on the Slido, so I'll just be asking my own after that if there are any more. I don't know, I think this one might be for you, Tony. It's what is public health doing in relation to working with emergency services and vaccination? I assume they mean flu vax. And I know ambulance have got this well under control because we've been talking to them at length, but what about the police? And if the police present to an aged care facility or somewhere else and they're not vaccinated, are they required to be? And
from those conversations we've been having is, do they have, in order to enter an aged care facility as part of the public health order, you're required to actually show evidence that you've been immunised, not just say you've been immunised.
yeah. Are the police exempt? Tony, any thoughts?
Oh, not that I know about, but I'm happy for Hayley to answer that.
Yes, so they are exempt, but they are highly encouraged to actually have the vaccination.
Like an NRL player.
Yeah. I don't think any of us want to go there. I think that just starts way too many arguments. Okay, look, I do have a question for the panel, and John kind of has been, well, somebody very wise has been asking this question on social media. We've seen what's currently happening in Victoria. Do you have confidence that we are not going to be facing the same situation in the next 2 weeks?
2 months.
I think none of us are out of the woods, really. I think Victoria was quite confident that they had the situation under control probably a few weeks ago, Tony. So hubris is wonderful, isn't it? So, I think time will tell. It's a new virus. We're learning it as we go, aren't we? But Tony can give a more.
Oh, look, we should all be nervous, I think. Yeah, and hence kind of mentioning those. For us here, I know we're dealing with Victorian cases and contacts, so we feel like we're really busy back in the thick of COVID. But having had 2 cases with who were both infectious in Hunter, New England in the last week, with a substantial bunch of people back in quarantine that we're following up each day, and I think almost certainly secondary cases from one of those. It's just a reminder that we're only a couple of cases away, and then a few doubling periods from being exactly where Victoria is. So I think it's extraordinary to be where we are. You saw that epi curve with really extraordinarily low levels of community transmission in New South Wales. That's an amazing effort. I don't think Victoria quite got there, but really, it only takes a few cases for it to snowball, particularly in some situations where it really is hard to pick up early signs of transmission and vulnerable communities. So no, we're not remotely relaxed. We're back on a surged footing, and whilst we recognise it's possible to come back from a really difficult space, there's absolutely no reason why we couldn't have a very similar situation in New South Wales.
Thank you. And I know there's been some efforts to get information out to accommodation providers and the like, to really encourage people who are here on holidays to point out to them where the testing centres are, so that we can make sure that if people become symptomatic or they're worried or they realise that somebody or some place that they live in a hotspot but they're actually on holidays, that they're able to know where to get tested. So I know that both the LHDs are doing some work currently on that, so I think that's a good step forward as well. Someone said yes, exempt only in emergency. There's a backup for 3 votes for your response there. Thank you to everyone.
I think the thing to say about it from my perspective, Catherine, is what I've been saying to the staff is that a bit like what Hayley was saying, it's the new normal, and I don't know that things are going to change. And really what we're asking to do the staff in hospital is what we've always asked them to do, which is around good infection control and wearing PPE and not coming to work when you're sick. But I think it's actually going to be good culturally, because I think in hospitals particularly, staff, particularly doctors, are the worst offenders, come to work sick and think, there's some bravado in it, I'll keep working for the next 10 days in a row. And I think this has actually been a really good opportunity to say to them, don't come here, we don't want to see you, go home, go and rest. So I think, that's going to, I hope that will be a good thing that comes out of it. And I think sometimes when you look at Hong Kong and Singapore and South Korea and all those places, I suspect some of their diligence to infection control is actually related to them having been through SARS the first time. That that kids always get their temperatures measured when they go to school, and people are washing their hands, and all that kind of stuff is just the way they've probably done business for the last 15 or 20 years.
Am I hearing that in Victoria, some hospital staff at least are being I don't know if it's advised to wear masks while they're at work or given the option, or do you know, John?
Look, I'm not sure about that. It certainly becomes an issue if you've got unfettered community transmission and you can't necessarily distinguish whether asymptomatic people may be pre-symptomatic or shedding the virus. And certainly we know that asymptomatic or pre-symptomatic people can have just as much virus on board, and so with close contact they will transmit. So it's really a decision based on the amount of undisclosed community transmission as to whether you go to a universal mask approach. Probably one of the most effective uses of masks is source containment, so putting the mask on people with respiratory illness as well.
Yeah, and that's what we've been saying in the ED too, I think. It's around community prevalence, and if the numbers increase, then there could be an expectation into the future that they'd wear masks all the time. But at the moment, some staff are still wearing masks, most of them aren't. But I think the other part about it that's difficult for me is that if and when there is a big COVID outbreak, our ability to be able to do our job in PPE is actually quite challenging. And I think one of the things I've learned out of COVID is I'm actually quite a sensory person. So we put things over our ears, we put them in front of our eyes, we put masks on, we can't smell, we can't taste, we can't see, we can't hear. And it is actually quite challenging to work in full PPE properly. But the other part of it is around people feeling comfortable to be able to work in that environment as well. So I suppose that's part of the reason why I haven't said to the staff, no, you don't need to wear a mask at work, but if you choose to wear it, then maybe that's good, because in a month when you might have to wear it every day, you'll feel more comfortable about doing it.
So an alternative that has become the vogue in America to some extent is face shields as a substitute for eye and mask protection. So that's another option that enhances communication and is less of a hindrance.
Still struggle, I have to say. But anyway, it's all about
it may
me.
not be as effective as a mask. There's no comparisons to masks versus face shields. They probably provide enough eye protection.
I know we here at the PHN have had a number of local and interstate agencies offer us face shields, a couple from motor racing teams and some local engineers and the like who are making them, and so we've made them available for the GPs and allied health people if they want them. Some people, particularly allied health clinicians who are working up close to people, feel like the patients feel more comfortable, so we can continue to provide those and at very low cost to anyone, so we can manage that for people. But I have to say they're varying in design and comfort, so I think there's something to be done around that as well.
I guess they're akin to those Perspex shields you see on desks now.
I know.
Separating clerical people from the unwashed public.
Yeah.
Yes. I think Tony...
Catherine, there's
Not a
one
technical
more.
term, is it?
Sorry, we'll just
I was
throw to
gonna
Tony
change
for...
the subject to say there's one more question there that we could address if we've got a second. Oh, I've lost audio. So Catherine, I was just saying there's one more question that's had an extra vote.
Yep, Tony, we'd be keen for you to answer that question, sorry.
Oh, well, look, the question was from Annette, just under what circumstances would a COVID-positive aged care resident be admitted to an acute facility? So I might throw that to Carolyn in the first place, and lots of work in this regard. So admission triggers for people from aged care who have COVID?
And so again, some of this is in the health pathways that I encourage you to look at, but I think it kind of goes back to what I was talking about before, but it's also a bit broader than that. So what's the person's goals of care? Will they benefit from being in hospital? What's the risk of them going to hospital? But also in the context of an outbreak, how overwhelmed is that aged care facility, how many staff have they got off sick, how many residents are they already dealing with. So I think it's one of those decisions that I would see in the ideal world that you actually make on a case-by-case, facility-by-facility decision, and there is no right and wrong answer. But for some of the residents, going to hospital is actually even going to the ED for a few hours and the families and the staff in the aged care facilities certainly talk about how many weeks it takes someone to get over, 6 hours in the ED and 2 hours in an ambulance. So I think, it goes back to risk and benefit, and I don't think there is a clear right and wrong answer, and it needs to be done sensitively and thoughtfully.
Hayley, did you want to make any comment on that?
I was thinking the exact same line as you. We've got to look at the individual and determine, because everyone's different. If the person's living with dementia, for example, how destructive would that be for that person, and what danger is that person in if we can't keep a constant review of them? So it's weighing it up for the individual.
Yeah, well, one of the families told me a couple of weeks ago, it's again one of the things that's also interesting with the less access for families to aged care facilities, that they're actually often seeing the residents in hospital. So they mightn't have actually seen their mum for a couple of months, and one of the families said to me, look, I think it was mum, I can't remember if it was a mum or a dad, but anyway, my relative has significant dementia. They know me when I see them, but we were only allowed to visit via a window, and we just thought that would be, and their hearing isn't very good, they can't see that well, and we thought it would be much more disturbing for us to have a window visit rather than not be able to see them in person. And then I said, so how was it seeing them here? And she said, he just said to me, oh, it was a he. He said, oh, hello dear, how are you? I haven't seen you for a while. But it wasn't like he was, he wasn't particularly stressed by the fact that he hadn't actually seen his daughter for a couple of months. I'm sure it was much more stressful for the daughter that she hadn't seen her dad for a couple of months. But from the resident's perspective, nothing had really changed.
It's really interesting because we heard a lot from the consumers that when the restrictions were reduced, they were saying, no, don't let our family back in because we are worried about our own health, so we're happy to have the restrictions. That's a lot of the feedback we received. So
That's
it's interesting.
isn't it? Yeah.
Well, I am going to call a halt to that. Mel, we did not get to throw a tricky question to you tonight, but we'll save that up for another day.
Okay.
So I will throw from the Newcastle studio, and to thank our panel, I will thank Mel and Tony on the screen, Carolyn, John and Hayley here for, I think, another really informative discussion. I will please ask you to take a couple of minutes to go to Slido, go to the evaluation poll, let us know whether we're on the right track here, getting the information that you are needing to continue to do your work to look after the community. There'll be more of these events on various topics. We're keeping Alison and the team really busy, but as long as we're needed, I think, to do that, we're more than happy to do that. So let us know, does the format work for you? Are there topics that you want to know more about? If there are questions we didn't answer tonight, please put that in the evaluation too, and we will definitely follow those up and get them back to you. So thank everybody. I'm going to give a shout out to my niece Bronwyn, who's texted me to say she's logged in, and thank everyone else and send you home for the evening. Thanks very much.